the border of, on the border of Queens and Long Island, part of the Northwell Health Network, if you've heard of that. I am going to be the incoming medical education chief for next year. I'm going to throw this over to Barrington.
I'm Barrington. I'm a third-year psychiatry resident at Vanderbilt right now in Nashville, Tennessee. I guess I'll be talking about safety, broadly speaking, and then I guess this is a PAMSA related. If you're interested, check out the American Journal of Psychiatry Residence Journal podcast. If you speak Cantonese or Mandarin, there's a episode there in that language as well. And there's a bunch of other culturally related stuff. I'll pass it off to Jackie.
Hello, I'm Jaclyn. I'm a second-year resident at Stony Brook Medicine, not too far away from Nancy, actually. We're both in Long Island, and I'm excited to be a part of this meeting today.
Okay, cool. So just like Jerry said, the first part is going to be didactics. I'm going to start with just a brief overview of mental statics exam. We kind of tried to put our heads together and brainstorm what would be the most relevant and also transferable, that would be relevant to all the different institutions that you're going to be at. You might hear some things that are a little bit different once you start. But overall, this is a good base to start from. So I'm going to share my screen. I put together like a one-pager. We can share out with the group if you find it helpful. When I started as an intern and it came down to writing the mental status exam, I felt like it took me so long because I just was trying to think of like the right words to describe what I was saying and having trouble thinking like, what word would help me describe this behavior and what word would be appropriate here. So this is sort of a list that walks you through the different parts of the exam and giving you terms to use to help describe what you see. So the first part, just understanding why the mental status exam is important. Sometimes it might feel like just checking off boxes, and maybe on some notes, it's just what you need to finish to put in your note, to submit your note. But a lot of times it's really helpful because it gives us a snapshot of how the person appeared at the time the note was written. So even though it feels kind of troublesome at sometimes, I have gone back to previous notes, looking at mental status exams from admission, and try to figure out, why was that person diagnosed with mania at that time? You want to focus on the pertinent negatives and positives. This is sort of like a kind of general example of what a mental status exam might look freeform in a note, in a progress note. This is specifically, I think I wrote this out when I was on inpatient. And so at the beginning of your mental status exam, you want to look at appearance and behavior. This can help you say something about their functionality, like the severity of their sickness, things like how old or how young they look, what they're wearing, are they disheveled, do they have a lot of tattoos, are there scars, focusing on grooming and hygiene to tell, are they taking care of themselves? Maybe they're being admitted because they have, they're really not eating, not drinking, not showering. And over time on the unit, you see that some of this is getting better, might give you an idea of how they're improving. Some other vocabulary, distress, are they hypervigilant? Remember, these are things you're observing about the patient. Cooperative, agitated, you're oddly related or well related. Looking at their gait when they get up to go to walk to you for the interview, you can monitor how they're walking. Are they stiff? Are they rigid? Rigidity might give you an idea about how they're tolerating their antipsychotic, because it can make you kind of rigid sometimes. Fidgety, restless, eye contact. And then speech, there are a couple domains that you can speak on. You can speak on quantity, hyperverbal, or the opposite, like poverty of speech. You can speak on fluency and clarity, speak on the rate. You know, one thing to point out here, an example why this can be so important is that someone maybe is talking fast versus talking pressured. And pressured, you'll learn, is one of the criteria for a manic episode. I would imagine it as when someone's manic, they're having racing thoughts, right? Flood of ideas. And it's so much so fast, it just kind of like comes out of their mouth. They can't even control it. That's how I would describe pressured. The rhythm, volume, tone. Thought process, you can speak on goal direction. Linear and circumstantial is probably not psychotic. Tangential, you're going to the psychotic range. Coherence, how much they're thinking. Looks like they're not thinking, you know, there's not much thought blocking, racing. Perseveration, neologisms. Neologisms when they come up with their own words and phrases. There's a lot more I could add here, but here's the starting point. Thought content is what are they thinking about? Here's where you would put like suicidality, delusions, paranoia. Then perceptual disturbances are the hallucinations. Mood is an easy one. Ask them what the mood is and you put it in your own words. Affect, there are a couple domains as well here. Quality. There's so many different ways of describing someone's affect. So, you know, here's a bank of them. There's way more you can add to it. So you have more words to help describe what a patient appears to be feeling. The range, the intensity, the stability. Labile, you guys might remember, that comes up when we're talking about mania too. Labile mood. Cognition, I think A&O, alert and oriented or not. If it's necessary, maybe you want to do an MMSE. Their attention or concentration. And then insight. So this one, I think a lot of times I actually didn't know really clearly when I went into residency, but it's specifically referring to the understanding of their illness and functionality. So someone who doesn't think they're sick, who won't take medications, you would say they have really poor insight. So it's specific on how they understand how they're doing. And then judgment, can they make good decisions? And impulse control, you know, are they aggressive? Do they constant redirection? Are they getting pure ends all the time? That helps you describe their impulse control. So you don't have to speak on all of these for every single person that you see and evaluate, but what's pertinent positives and negatives are helpful. And I'm gonna stop there.
No, we had a question in the chat, which I guess might be better
What is
now.
dysphoric?
What would you say dysphoric is? Yeah.
Yeah, like sad, depressed. You guys want to add anything else to that?
I guess kind of like the affect versus mood. Some people say like affect is like the current weather, but then the mood is like kind of the climate, if I remember correctly. And so if someone looks like they've like kind of been, they look kind of sad, look kind of depressed, I guess there's also other lugubrious. One of my attendings like to use lugubrious. It's like just looks, sounds sad and dismal. Lugubrious.
Oh, I don't know that word.
It's the SAT. I learned it like a year ago. I was like, looking and sounding sad or dismal. That I might be in the same family as dysphoric.
Okay.
I don't know if you have any other thoughts, Jaclyn.
So it would be basically the opposite direction of euphoria. So euphoria is like really happy, pretty much up. And then dysphoria is sort of like more down. So someone who's like very sad, or in a term like gender dysphoria, someone who maybe is struggling with a bit of their gender identity, or just have a lot of discomfort mentally or even physically, if that explains it.
Sometimes I'll, when I ask people about their mood, you can I'll say like, you know, it's normal to have ups and downs kind of in the middle. And then euphoria or being elevated is like when you have ups, like you're all the way up here and you stay up here for a while, versus like dysphoria, you're down all the way down and it's persistent. Okay, let's off
Good question. Good question. So we've already introduced ourselves. So I'm just going to talk generally about safety. So I guess when you think about safety, might be a couple of things you think about, at least when it comes to rising fourth years and incoming interns. Hopefully, you can think about two things, and that would be safety assessment, which may include suicide risk, violence assessment, and then safety of yourself. And so we'll talk about both of these in the next 9 minutes. So important things, especially develop over training, is some sort of suicide and violence risk assessment. Sad persons is a mnemonic that some people like to use. Risk factors include like male or sex, elderly age, depression, or mood disorders, previous attempts. That's the biggest one. E is for ethanol or like drugs. R is for rational thinking loss or psychosis. S is for if they're single, not married, or divorced. Organized plan, no social support, physical illness, sickness. Other factors include like hopelessness, impulsivity, anxiety, lack of future orientation, increased stress, agitation, some recent loss. I guess sometimes you can see like in the boards like low 5-HAAA in the system, which is a metabolite of serotonin. So you'll end up developing your own approach. There's some protective factors as here listed there. A responsibility to like various things, or feeling responsible can be protective in some ways. Sometimes it can be a burden for some people. And I guess I know for some, especially me earlier on, you can start off trying to like talk the patient out of like some suicide or suicidal thoughts, but kind of your role is mainly to assess the suicide risk and then intervene as appropriate from there. So various scales, the ASQ, CSSRS, your institution or probably your senior residents may have some own way that they do it. I know here we have like some form that you click some boxes. Hopefully, you know, this just more fosters conversation, and so that you feel comfortable asking that wherever you're at for your residents and attendings. If you're discharging a patient, you want a really detailed safety plan as much as you can, usually on inpatient units. Social workers can work with you, or some other resident or someone can help you and the patient find some safety plan with contingency steps, especially if suicidal ideations, intense actions, whatever returns. For violence risk assessments, there's a lot of factors. You know, history of violent acts is predictive of future violent acts. Kind of makes sense in some ways. History of abuse and neglect, substance use, means for violence, such as having firearms, and kind of depending on your state and the severity and the situation, you may have a duty to warn. If that violence is directed towards you, we'll get to that in a little bit. Your safety is most important when considering treating patients in the long term. So other considerations, you know, all the things I just mentioned are important, but as much as you can, especially if you have time in a regular sort of H&P, assessing other history, you can have elevated chronic risk, but low acute risk, and then sometimes ED or ED psych attendings will document that elevated chronic risk, low acute risk, and they're like, they always come here, they always present with this, and that's why they feel comfortable discharging someone. Static versus dynamic factors, can't really change your age too quickly, but in terms of current agitation or current irritation or some other factors, you can, access to firearms, I guess, is maybe a dynamic factor. Also, the Joint Commission requires some documentation. Also want to think about if they have capacity, which we'll get into in a little bit. Then also you can always get collateral, or you can usually try to get some collateral. So you always will get collateral. Based off of that, you should make a decision kind of with your attendings or co-residents, and you can decide if you would like to let them go voluntarily, if this is an involuntarily commitment situation. We're always taught to take care of the patient, put the patient's interests first. Well, I guess in some ways, it's taking the patient's health first. And also, if someone has some suicide ideation, homicide ideation, to where you feel that they're a danger to themselves, like right now, and they tell you they're going to go out and run into the street and kill themselves, it probably behooves you to not let them do that, at least for some short period of time, depending on your state. You got to defend I know there's states that have you have to defend your decision in a court of law. So you're usually never alone, especially in MS4 year and then intern year. I just put this here. If you end up needing to commit someone, then Sam said some best practices you can consider. And so again, you should consider your states. Some states are more conservative or liberal than others. So just kind of talk and what's your institutional culture, learn about that. So enough about patients. Oh, okay, so take home points. Lots of factors, continue to develop safety risk assessment, and you have to consider a lot of things, not just the patient's stated interests in these situations. So now, safety for ourselves. I don't know if y'all are aware. I know I got asked this when people were interviewing here. I know, and it's not unique to any of us. At the major university hospital, there's a psychiatry resident that was like stabbed multiple times, leading to, at least what articles say, disability. And like, this is a super tragic situation. Like, it's really sad. And I don't know the people involved, and can't comment more than that of what I've seen in articles, but it's very sad overall. And so there's a lot of factors that go into this, and I think overall, just your safety is important. Can't stress that enough. And so I also want to think about outpatient offices and like non-psychiatry settings have even lower level of like, I don't know if you can call it security or just like preparedness. In some ways, having that higher preparedness on inpatient psych units may actually be more helpful. I think, like I see an article every so often about some non-psychiatrist in their office getting like hurt. There was like no one there to stop it at that time. So I'll talk about modifiable things and not modifiable things. So, well, I conceptualize it. There's things about yourself that you can modify. I mean, what you're wearing. I guess if you're wearing shoes that look nice but are really uncomfortable and not very mobile, then it might not be the best situation. If you're well rested, your listeners, that's probably a good thing. Just learning about patient interactions as you go along in training, your own intuition about it. You can do as much as you can if you want to pre-chart on a patient or get handoff. Patient rapport as well. I guess that's modifiable situational factor. So patient rapport in the moment, support staff, your relationship with them. Sometimes having good relationships can be really helpful. Knowledge of the safety protocols at your hospital, physical, chemical restraints. I think that's a very nuanced conversation, not for today. Positioning with you and the patient. I've always heard, don't let it where it's like the door and then the patient and then you. You can always have chaperones or supervision, items around you. Like if in our hospital, there's like really heavy chairs, so you can't really get a chair thrown at you. But there's other like smaller objects like styrofoam cups. You can always call a code too if you're really worried. There's a lot of other factors. So not modifiable factors, I mean, kind of your own demographics at that time. And there's a lot of other ones, not modifiable situational factors, like you're probably going to be on the rotation for at least a week or two. You're probably going to have a certain set of rotations. and I guess this is not an exhaustive list, but just more to get you thinking about. Some stuff is modifiable, and you do have a little bit of control over that with overall consideration. Make sure you're safe as much as you can while still being mindful of other factors involved. And so really, I guess the preparedness is probably the most important in terms of what you know and how you can sort of approach a situation and sort of be as safe as possible or manage risk depending on how you look at it. So, well, that's it for me. What are your thoughts on safety contracts and patients who have thought of suicide? I guess I haven't looked it up recently, but I remember, I feel like this comes up every couple months, at least for me, but safety contracts in terms of like, from what I know from the evidence base, aren't fantastic. I don't know if y'all have other thoughts or maybe a different update.
I agree. You can't really tell someone to say, promise me you won't kill yourself. There's not a lot of like, there's not a lot of evidence that it works. But what you can do is do safety planning with a patient. And what that looks like instead is helping them identify what their triggers are. There's like a form that you fill out with them. It's like a worksheet, I guess, helping them identify their triggers, what coping skills they can use, who they can talk to as a distraction, who can talk to for help, what they're going to. So it's basically, when someone is in that state, they can't think clearly, and it helps them think more clearly, gives them a plan, and hopefully will deter them from carrying out whatever urges that they have.
Good question. I'll pass off to Jaclyn.
Okay, so I'm going to share from my second device. Give me 1 second.
Hello everyone, I am Jaclyn from Stony Brook Medicine in New York. Nice to meet you all. So today we'll be talking about PRN medications for different psychiatric scenarios in the hospital setting. PRN stands for pro re nata, which in Latin means as needed. So we'll be talking about as needed medications that you will need to use for anxiety, sleep, and agitation. For anxiety PRNs, we typically use Benadryl or Vistaril. These are antihistamine medications. When someone asks me what is Vistaril or hydroxyzine, I usually say that it's like a cousin to Benadryl because it sort of has the same pathway. In terms of the dose, we typically start with 25 to 50 milligrams and we go up as needed. Sometimes I also use a little bit of low-dose Seroquel, starting at around 25 to 50 milligrams, and I also go up as needed. The third class of medications that we typically use is benzos. So when you're discussing benzos, there's a few things that you have to look out for. If the patient is on any other medication that may be suppressing their respiration, that's really important. In terms of benzos, you also want to know what medication you're using because they vary largely in potency. So 1 milligram of Ativan is the same as 5 milligrams of Valium or 25 milligrams of Librium. 1 milligram of Ativan is also the same as 0.5 of Xanax and 0.25 of Klonopin. So you really want to know, in terms of your medications, if you're going up or down on a dose, exactly what that's equal to. For kids, we typically stick with Benadryl, Vistaril, or sometimes we do beta blockers like propranolol. I'll start with 5 to 10 milligrams and I'll go up as needed. Let's now talk about PRN medications for sleep. So for sleep, it's really important to educate your patients on establishing good sleep hygiene. This means having a consistent night routine for you to mentally and physically wind down at night. This usually means dimming the lights, not having any electronics 30 to 60 minutes before you want to go to bed, not doing anything too intense like exercise or watching television, maybe putting on some light music, and ultimately allowing your mind to get to its resting state. The medications that we typically start with is also Vistaril and Benadryl. You can start with 25 to 50 milligrams and go up on that. Other medications include melatonin, 1 milligram up to 10 milligrams nightly, trazodone, where we start with 25 to 50 milligrams at night, low-dose Seroquel, again, from 25 to 250 milligrams, and the two medications that I really like for elderly patients is one, Remeron, which we start at 7.5 milligrams. And Remeron is great because it targets appetite, mood, and sleep. The second medication is Ramelteon, which starts at 8 milligrams. And Ramelteon is great if you have a patient who's elderly and prone to developing delirium in the hospital. Other medications that we also often use are Doxepin, which starts at 25 milligrams and up, and Temazepam, which starts at 7.5 milligrams and up. Now let's talk agitation PRNs. So first of all, what is agitation? Agitation in the hospital usually results from the patient being not comfortable. It could be from their medication effects, it could be from their illness, or just overall frustration with being in the hospital. Your first line of defense should always be de-escalation. And with de-escalation, you really want to make sure that you're maintaining an appropriate distance from the patient, having fair eye contact, talking in a sincere tone with them, and trying to avoid any sort of confrontation or antagonism. A lot of this is going to be redirection for the patient, which is essentially acknowledging that they are frustrated and maybe agitated and trying to shift the focus into how the problem can be solved, whatever that could be. Sometimes it could be aligning your goals with the patient and trying to see things in a bigger picture. And ultimately, being aware of the tension in the situation and acting appropriately. Typically, it's okay to also call in other staff members to be around you. That way, there's no safety issues. So say you've tried offering verbal redirection, supportive therapy, comfort carts, snacks, things like that, and the patient is just amping up. Now you have to look at what medications you want to give the patient. Number one, always check any medication allergies they may have in your chart, because you don't want to give them Haldol if they are allergic to Haldol and eventually have them go into a allergic reaction. That might be even worse. So for kids, we typically stick with Vistaril or Benadryl as well, 25 to 50 milligrams and going up as needed. You can also do Risperdal, 2 milligrams. And the great thing about Risperdal is that it comes in an Risperdal M-Tab formula, which is a dissolvable tablet in case you're concerned that they're not going to swallow the pill. Another medication that we use is Thorazine, and we typically start at 50 milligrams and go up as needed. And it's great because Thorazine, you can either offer oral medication or inject them. If you're concerned about them cheeking, meaning that they're putting the medication under their tongue or hiding in their cheeks, you can do something called a mouth check, in which usually the nursing staff will check and make sure that they're swallowing the medication and not hiding it in their mouths. For adults who get agitated, we do other combinations. 5 and 2, which is 5 of Haldol and 2 of Ativan, which can be given as PO, oral intake, or IM, intramuscular. If they're really agitated, you can even throw in a 50, and that would be 5 to 50, 50 for Benadryl, also PO or IM. Other times, we can also consider doing Zyprexa, which is also PO or IM. And with Zyprexa, we usually start at 2.5 and we go up to 10 or more. Seroquel is another option, again, from 50 to 200 plus, and Thorazine, essentially 50 plus. Remember that every time we give benzos, so in this case Ativan, we want to make sure that we monitor for any respiratory depression, especially if they're on other medications that may cause respiratory depression. You also want to make sure that you don't give Zyprexa and Ativan IM together. This can actually cause increased sedation, sleepiness, loss of consciousness, and may even precipitate a slow or irregular heartbeat. So you want to make sure that you do not give IM Zyprexa and IM Ativan together. After you give any of these medications, you do want to check the patient's vitals, make sure that the patient's okay following administration, and monitor their QTC on an EKG. If they're getting a lot of these medications, you might want to get an EKG on a daily basis to make sure that the QTC is not more than 500. In the case that this sort of goes awry, the patient may require restraints, and that will be on a different video. So you just loaded up your patient with a ton of antipsychotics. What should you be worried about? EPS, extrapyramidal symptoms. This is drug-induced movement disorders that are associated with antipsychotic blockade of the nigrostriatodopamine tracts. TLDR, essentially your patient is going to have a surge in cholinergic activity. You want to be worried about certain symptoms. First one is acute dystonia, which is characterized by sustained contractions of the neck, the orofacial muscles, and the tongue. Typically, you want to treat with anticholinergics. This includes Benadryl 25 to 50 milligrams, PO or IM, Q4 for a max of 200 milligrams. You could do benztropine 1 to 2 milligrams, PO or IM, Q4, max of 6 milligrams. Akathisia is next, which is inability to sit in Greek. It's the subjective feeling of anxiety, restlessness, and this irresistible urge to move. Sometimes this can result in severe agitation and irritability in your patients. You want to give a benzo or propranolol. Next is medication-induced Parkinsonism or pseudo-Parkinsonism, and this is usually characterized by cogwheel rigidity, instability, stoop posture, things that you would expect in Parkinsonism. And the medication for this would be benztropine. Last one and most important is tardive dyskinesia. These are involuntary movements of the muscles of the face, the mouth, and the tongue. And typically you'll see things like grimacing, chewing, lip smacking, and also patients sticking out their tongues. Typically with this, you want to stop the medication immediately. Consider switching to clozapine if they are on a standing antipsychotic, and trial valbenazine. And that is it for EPS.
I just want to say it is always weird hearing yourself talk when it's an audio recording. I know that that's a lot of information, but that was a bunch of PRN medications and scenarios that I wish I had been briefed on before I started psychiatry residency. And I know that having some sort of cheat sheet with a bunch of these medications may come in handy when you're in the inpatient or the ED setting, or even if you're getting consulted on patients who are acutely agitated or needing medications for anxiety and sleep. Does anyone have any questions?
It's very good. Good. I would agree. Sometimes institutions have like the same approach, I guess, maybe slightly different medications, but all the ones are all very reasonable. Yeah.
Yeah, so I think we have few enough people that if you want to ask your question out loud, you can turn your video on, unmute yourself and do so. But if not, just put them in the chat and I can read them out. Okay, so there's a question in the chat about advice for away rotations and how to stand out. Mostly in terms of what the expectations are as a sub-I and how to impress the team.
Yeah, I can throw out some thoughts. I mean, I don't know with I guess orientations I've heard, and I guess some, you know, if you have any other thoughts, I've heard not necessarily required, I guess, with COVID. I mean, maybe it's more helpful to get to know a place a little bit more. And I guess I interviewed, and when I was considering OAs, it was during pre-COVID. So open to different thoughts. I think in terms of standing out in a good way, I mean, I guess there's the classic be a team player, you know, get to know people, get to know patients. I think one of the learning milestones for med students to residents and then junior to more senior residents is synthesizing the information and trying to have a well thought out differential and then best diagnosis, and then formulating a treatment plan, getting down to like, you know, doses of medications, and then like a taper or titrate plan, and then sort of next steps, if you were to sum that all up in 2 words. So or maybe diagnostic, clarity, and next steps overall.
can add some stuff to here too. I reviewed like applications this year, and I feel like things that jumped out were when in like Rex and like in the MISP, people talk about, like Barrington say, like team player, like well liked. And I think that comes from, you know, making sure when you walk onto the unit that you say hi, good morning, you say hi to the nurses, you get people's names. And then also, I think when you get feedback from your supervisors, really listen and make a note of them so that you can incorporate it into your next note. I don't think it's reasonable to get it right like the next time immediately after getting the feedback, but over time throughout your rotation, showing that you've really been listening and integrating some of that feedback into your care with the patients. Stay curious, ask questions. Yeah.
Going off of that, I would definitely include also asking for feedback and being responsive to the feedback, like what Nancy was saying. I'd also say that you don't have to be the smartest person in that area, but sometimes if you are somehow able to stay updated with one or two recent research articles or a study, and if you ever reference it, it is definitely impressive to the residents as well, and maybe some of the attendings. So it's nice sort of drawing from that. If you have information on things like cultural psychiatry or cultural stigmas, and you include that somehow into your patient evaluation, that's also really impressive. But otherwise, being a team player, showing that you get along with everyone and that you're willing to put in the work and energy to being an effective clinician and trainee in the end would be very important for someone who's ultimately looking to hire you.
Okay, we had another question come in on the chat about how do you balance time between writing comprehensive notes and seeing patients?
I struggled with this, so maybe I'll take this question. I think it is really hard because when you first start out, you don't know what's pertinent, what's not, and then you end up like wanting to write everything, and then you run out of time. So, you know, I think first is to kind of figure out what your workflow is, like talk to people, what works well for them. Do they see all their patients first? Because, you know, there's more time in the afternoon to write their notes, like try to figure out what other people are doing to optimize your workflow. The other is like, keep in mind what the purpose of your note is for. If it is a progress note and you need to document just changes in their presentation day to day, then make sure that's in there. And maybe some of the other stuff, like all the social history that you collected, which is great, may not need to be so important for the note. So reminding yourself of the purpose might help you cut out some of the extra stuff.
Some tips I have is you can ask your program if they can get you a dragon or something to dictate your notes. I know that I do see some of you guys are from Stony Brook. We have an app on our phone where we can open up PowerChart and essentially dictate straight onto the notes and then drag it in when we go to computer. I think it's really helpful. And I had some colleagues who also ended up buying dragons to dictate their notes, and it just saved a ton of time. The second thing is also writing templates. If you get consulted for, say, capacity, you can have capacity template, delirium template, agitation template, and you can essentially pull these templates in and sort of edit them along the way. In terms of right now, since you're at a fresh start, you can try asking any of your seniors if they have any good templates to use, or sort of formulate your own throughout the next few months so that you can save time for the future.
Yeah, all really good. I don't really have anything major to add if there's other questions.
Hi, I'm a third year medical student. and I'm really interested in child psychiatry. So I was wondering if any one of you would have any advice for both the audience of third-year medical students, as well as rising fourth years and interns, but what they should be thinking about as they start the residency program, and what they should be considering if they have particular interests in particular fellowships and areas.
Yeah, I can comment. I guess, are y'all on any child track or applying for child fellowship, Nancy or Jackie?
I'm actually considering it right now in terms of doing a fast track to a child fellowship. So just to answer your question, for that, you can apply to any, I think for the most part, any psychiatry residency program, and most of them, at least, most of them in New York, allows you to graduate early. So instead of 4 years, you can do 3 years, and it goes straight into a 2-year fellowship track at another hospital that offers child fellowship. Some programs like mine also have a 5-year program where you can apply straight into residency and fellowship combined. And our school offers 2 to 3 spots every year for that. So if you're for sure interested in child psych, you can consider doing that. That way your admission to a fellowship is guaranteed. I think that if you're interested in any fellowships, I would consider looking at programs that allows you to do electives earlier in the year. I know that not every program allows a ton of elective time during their 2nd year, sometimes not even until 3rd year. So I would highly recommend looking at the program curriculum and seeing if there's elective times and how early you get these electives. If you're interested in forensic psychiatry, I had friends who ended up applying there, and they actually required that you had at least 1 month of forensics experience before applying to a forensic fellowship. And I think the same thing goes with other things like addiction, neuropsych. If you show your interest in that, and also it doesn't hurt to have some research in the field of interest. So that's what I would recommend if you have some time as a medical student right now to get involved in research, and also research your curriculum that you're interested in.
I think there's some other considerations as well. If you look at the ACGME requirements, and someone correct me if I'm wrong, I think there's like only 2 or 3 months of like full-time equivalents of required child exposure training in residency, which is in some ways more than 0. It's not that much. Some, like Jackie was saying, like some places, like I'm on the track and starting the fellowship in July. The interns rotate a month of child inpatient. We have a month of child consults. Some residencies only have like an outpatient year, half day or full day clinic of child psychiatry. So that's a consideration. If you're thinking about it, but you like don't want to commit, then that's something to consider. Also, the different places call child track whatever they want. They can call it child interest, child track, whatever. But as Jackie was saying, some places have more commitment. They'll commit more to you, and they'll guarantee you a spot. Now, some places they don't always guarantee funding. If you want to switch out of it, you might have a 4th year if you just want to do categorical adult. So that's a consideration too. The requirements can overlap. If you want to do 5 years total track, the ACGM requirements list up to 25% can be overlapped. And then if you want to do it after 4 years of a categorical adult, that's also possible too. Some people just think with opportunity cost of a 1 year of attending salary, which is like $200,000. So that's something to consider. Otherwise, there's one other thing, but I can't think of it right now. That's a very good question.
You also don't need to know for sure if you're going to do child until probably your 2nd year, So you have some time.
Thank you all for answering my question, and those are really great answers. And also thank you so much for taking your time to do this presentation.
Looks like we have 2 more questions in the chat. One of them is just about how you evaluate programs, like I guess when you're making your rank list.
There's a lot of factors to consider. I think Jackie and Nancy are probably all slightly different, and a lot of people have similar things. I mean, the program itself, I mean, is it accredited? Most of the places are accredited, I guess. How old is it? There's also location is really important, especially if you know, you want to be closer to family, you want to go away somewhere. Exposure to certain things can be important. Also, you can consider elective time for interest in something. Oh, and for child, one of my mentors told me, you know, don't shortchange the adult residency. Don't like choose somewhere for their child fellowship when you still have to go through adult residency. Pharmacotherapy, psychoanalysis. You know, I think talking to the residents, I know there's those resident socials. After a while, they all kind of start to sound the same. But if you get to know like a couple residents and like can talk to them one-on-one, sometimes that can be really helpful for evaluating the culture of a program and what they think. Because all the websites look really pretty and everyone's balanced equally. But really, you know, getting the inside scoop off the record is important.
I guess for me, I think location was really huge. You're going to be living in this place for 4 years. You know, you want to enjoy that time. And especially in psychiatry, you have a little bit more time in your schedule. You know, you want to be around, be able to enjoy the place that you're living in, how you spend your free time. I remember when I was interviewing, just picking up on vibes of like the support from administration, the quality of the program director, how supportive they were, how focused they were on the experience of the residents on teaching versus like just having warm bodies to cover call. Hospitals that are resident run versus like resident dependent versus the hospitals that aren't. If it's not a resident dependent hospital, then a lot of the times, you know, if you're sick, if you need to call out, it's not as big of a deal. Attendings will cover. If it is resident dependent, likely hours are going to be longer. Yeah, it's a little, probably might be a little more stressful. Electives, I think flexibility, my program specifically, I love because we get so much elective time and like protected time to do projects. So little things like that makes programs start to separate out.
Yeah, I would say that I primarily looked at places that were university hospitals because I wanted the opportunity to work with professors or other psychiatrists and psychologists on research. I also wanted to pick a place that had medical students. I just enjoyed my experience working with residents when I was training. So I wanted to be in a place where I could also continue interacting with medical students. And the last thing that was really important for me was geography and also food, like what the food situation looked like around the hospital, in the hospital, the cafeteria, things like that. And yeah, that was pretty much it.
Okay, looks like we got two more questions, but it looks like it'd be a good one to end on. First half is, what are any good resources or tips about psychiatry for people that aren't going into it, as well as resources to learn about cultural psychiatry?
I think trying to go into rotation and realizing that there is something that can be learned, some sort of skill or tool that will really advance your care in whatever field that you're going into. And maybe that can be motivation to really stay curious and be invested in the rotation. Because ultimately, you know, people can pick up pretty easily if you're tuned out or if you're not interested. There is something that can be, you know, you learn how to work with borderline patients, and it helps so much on like an inpatient medicine floor. So finding those pieces of pearls that you can take with you. And then the cultural psychiatry piece, I think there are some, like, there are a lot of resources out there, but I can't think of them offhand. I think there was a speaker at one of the conferences recently who pretty much coined the term cultural psychiatry. Francis, do you guys remember this?
Francis Liu.
Yeah, I'm pretty sure he coined the phrase cultural psychiatry. He's like the professor over at UC Davis, I believe. Anyway, maybe you can try looking up that name. And also in the DSM-5, so the handbook for diagnoses in psychiatry, there's a whole section on cultural psychiatry as well.
Yeah.
And just ask questions.
Yeah, so I know Francis Liu is really big. A lot of institutions are starting to, add stuff to what is probably defined as cultural psychiatry. Whatever institutions you're at, check out the website, see, you can talk to some faculty about it. I know major universities do put some stuff out there. There's also the SSPC, so the Society for Studying Psychiatry and Culture. And Francis Liu came to our institution and said that's his favorite conference. So if he says any coined the term, then it sounds like it's been pretty good. I hope to go at some point.
Think so? I'm not sure.
Yeah. Other question was for people not going into psychiatry as a field. I feel like when I interact with teams, they're just like, I don't know what's going on with this patient, or they're just off, or no, they're acting strange, and you're like, well, what exactly are they doing? And they just say, oh, they just repeat, they're acting strange. It's like, okay, that doesn't help. So quantifying what is going on, I guess, in more words, and sometimes that can involve the mental status exam. So the reason why I guess those things that Nancy talked about are the most important parts of the mental status exam is because those are the things that we think about, quote unquote, normal or abnormal.
Okay, looks like we don't have anything else. So it's just thanks to all of you guys for volunteering your time. And then it might take a few days, but we'll most likely be getting the recording out to you as well as Nancy's handout. And yeah, I think that's everything. So just, if you wouldn't mind giving everybody a virtual round of applause.
We can share, or I can share my contact information as well. I've never received a virtual round of applause before. That was interesting.
Yeah,
Very cool. And you can feel free to send out our emails if they want to reach out for any questions.
Yeah.